The categories included in the ACE study do not represent all possible forms of abuse, neglect, household challenges, and other adversities that children may experience. Children can experience many other forms of trauma, including peer victimization, loss of a parent, community violence, historical trauma, war, poverty, and much more. However, the categories included in the ACE study provide a good snapshot of things that occurred during childhood.
Well, the ACE study was groundbreaking, or pioneering, if you will, because no one had really tried to look at what happened as children and how it might have an effect later on into adulthood. Most people had looked at maybe some of the injuries, especially physical abuse of children, and how that might have translated into some very specific and oftentimes kind of short-term kind of things. But no one had really looked at, an adult population and seen that, there are other kinds of diseases and conditions that seem to be associated with the adverse childhood experiences. So the ACE study was fantastic in the sense that it showed us those things that now we could try to act on it. So whether it was diabetes or tobacco use, or things like high blood pressure, or things like mental illness, all of those things were shown to be associated with the ACEs that people had not known before and researchers had not known before.
Collecting ACE data is really important for informing prevention. For one thing, it really helps us create awareness about this problem. It wasn't too many years ago that people were totally unaware. Violence was thought of as an injury problem alone, just something that caused physical injury. People didn't understand that it also is a factor that contributes to mental health problems, infectious diseases, and chronic diseases. The ACE data has allowed us to demonstrate that, to allow us to make people aware of that. And that is critically important. The first thing you need in order to create a public health response to a problem is to have the public policymakers be aware of the nature of the problem and its full extent. And the ACE data has been critical to accomplishing that.
As a part of the study, participants indicated which, if any, ACEs they had experienced before they turned 18. Based on their responses, each participant was assigned an ACE score between 0 and 10 that was used to estimate the amount of adversity the participant was exposed to as a child. In addition to collecting data about their exposure to ACEs, the study assessed participants' current health status and health behaviors to identify connections between childhood adversity and adult health and well-being. The study uncovered a strong relationship between exposure to ACEs and numerous conditions that have a negative impact on lifetime health and well-being. To date, ACEs have been associated with over 40 negative outcomes. Findings from the ACE study led to the development of a conceptual framework that helps explain the connections between early adversities and negative outcomes. As depicted in the ACE pyramid, early adversities can lead to disrupted neurodevelopment, social, emotional, and cognitive impairment, and the adoption of high-risk behaviors that can lead to an increased risk for disease, disability, social problems, and ultimately, early death. While an ACE score provides information about a person's exposure to early adversity, it does have its limitations. The ACE score was developed as a research tool, not as a diagnostic tool. It was designed as a means to collect data about exposure to ACEs. ACE scores do not account for the severity or frequency of adversities, nor do they account for age of onset or a person's relationship to the perpetrator. Despite these limitations, the study provided a model for data collection about ACEs and demonstrated the value of these data. Many states now collect ACE data through the Behavioral Risk Factor Surveillance System, BRFSS, an annual state-based telephone survey that gathers information from adults in the U.S. regarding their health conditions and behaviors. These continued data collection efforts provide ongoing and updated information about ACEs that inform prevention and treatment initiatives.
I think it's important for us to take data and put it into practice, if you will. And so how can data help us in regards to ACEs is not only knowing the extent of the problem and some of the patterns of the problem, but then also making sure that we get that information to those that are the decision makers, those that are funding programs, those who are actually administering programs, so that they can take that information and actually put it into practice. I think that's the primary reason that we want to collect that information, is so we can get it to the people who need to know so that they can make the right decisions. Another thing is actually taking that information and getting it into the hands of prevention program administrators and practitioners, so that now that they know this information, they can be able to focus their programs on particular populations that might be at risk. So we're taking the ACEs, trying to expand where it's being used, and then not only expanding where it's being used, but also expanding how it's being used, so that the right kind of people can make decisions about how to focus on population.
The ACE data is used in increasingly more ways today. First of all, in public health, we use it to show the proportion of populations that are exposed to these adversities and these risk factors. And that's very important for us to identify high-risk populations and to target intervention strategies, prevention strategies.
Okay, let's review key points covered in this lesson.